Enough for getting babysitters, spending time away from your family, and coming out here tonight. It means a lot to me, but I think it's great for everybody here too, because hopefully we can get a lot of feedback. We're very lucky because Joe Pharez agreed to come down from Vail. He's big time in my mind, and he's undergone the procedure, so in my mind he knows even more. So he's going to share his experience with us at the end of the talk. I think that'll be wonderful. So I'm very grateful for that. The only thing I wonder, should we turn down the lights a little bit just to make sure the videos look dark enough or light enough, I guess? A couple of people I need to thank tonight. Valerie is here from our office, which means a lot to me because it's good for her to kind of know everything that we're doing and everything that we've advanced and done. Andrea started to work with us. She's the head of our research and our database now, and Tara's been helping us. For them, for me, if there's one thing that patients are upset about losing, it's their game ready. So I highly encourage you guys. It's a great icing unit, compression unit. It's great for patients after surgeries or if you just need to cool them down for a little bit. So I'd really consider getting that set up. Lastly, need to thank Danielle. She's organized this talk now for the last couple of years. She's got a great database and name list. So anybody who does not get an email from her, I'd encourage you to sign up with her to make sure that we can have your name for future talks. Okay? So I guess my only disclosure is I do work with Smith & Nephew currently. We design some instruments and we also do some education for them. That doesn't really have any impact on this talk at all. Goals tonight, I'm going to backtrack again just like we do every time. We'll go through FAI again for new people, labral tears, kind of go through how I come up with the diagnosis and confirm that that's the problem. And then I'll just kind of look at what's changed in the last year. We'll go through all of that. I want to follow up on the Ganz osteotomies that I'm doing in conjunction with Ron Hugate. He's really the one that's doing the Ganz osteotomies. He's brilliant at the surgery. I'm very impressed with what he's been able to do with that. I do the hip arthroscopy portion first. Then I'm going to get into labral reconstruction, the rationale, how I got here, why I do it, and what our results have been. And then lastly, Joe is going to close the talk. He's going to talk about his experience. And for me, that's the meat of this talk, and I think that's what you guys will find the most useful because I'm not a physical therapist. I can't pretend to tell you how to rehab. I can just tell you the pitfalls that sometimes I see, and hopefully that'll be helpful for everybody. So the first thing I want you to do is I want you to look at your neighbor front, back, and side and pat each other on the back. We are way better than we used to be a couple years ago. I think everybody's doing a great job at picking up these injuries, and it's been very, very helpful to get people earlier. I think it's made a huge difference. Now that being said, we just had a gentleman that I just said goodbye to tonight who has had 2 failed back surgeries and a couple other procedures, including a spinal cord stimulator for what was a hip problem the whole time. And so he was actually dismissed by a spine surgeon and told that you're probably just depressed. And so I hope that everybody out there kind of takes that to heart, takes that story on, and uses it as a motivation to get better. Last person I forgot to thank and really introduce is Sean Carnes. So he's actually my new PA. He's been with me now for a couple months. He's great. So the nice thing about having him is we get in the OR a little bit more. But then also, if you need us at any point, you give a call and you'll get Sean through me or vice versa. And so we're much more accessible than I used to be when it was just me. So we're more efficient. I think we're a better team now. When you look at impingement, what is impingement? Again, there are the 2 types. There's the cam and the pincer. Cam is basically an aspherical femoral head-neck junction. And so when you rotate that ball into the cup, it just simply doesn't fit. And that poor labrum on the very front is what gets whacked. That's what gets torn. That's what hurts. But it's the underlying impingement that caused the problem in the first place. The pincer is the same problem, just simply on the cup side. The cup in the front is simply too prominent. So the same thing. We live in flexion as we flex our hip up. That's what we impinge against. That's how you tear the labrum. Either way, this conflict, whether it's cam or pincer, whether it's both, it's a conflict with anterior hip flexion and internal rotation. Okay? Now, when we look at the etiology and presentation, I really think that everybody is unique. You know, we're all blessed with a genetic heritage in a certain construct. And then as we develop, the sports that we play can promote the development of further impingement. For example, ice hockey or soccer, all the twisting and pivoting that goes through with that can make the impingement actually worse. When we look at the distribution, cam probably is 25%. Pincer in isolation is pretty rare. The mixed pattern, 73%. I actually think it's a mixed pattern in almost 100%. Because if you have impingement, these labral tears don't start just one day. Symptoms may, but you've had the impingement for several years leading up to it. So there's going to be some element of bony change on both sides of the joint which worsens the situation. In other words, if you have a pincer for a long period of time, you're going to develop a reactive cam. If you have a cam for a long period of time, you'll develop some reactive osteophyte on the front of the cup. You'll get a reactive pincer. So the two go together. When you look at the timing of symptoms, this is one of the big problems that I think we have in Colorado. It's really the activity level or type of sport combined with the degree of impingement that brings about the problem. So in other words, if you have a massive degree of impingement and a relatively inactive person, you might see them pretty early. Usually what we see is relatively minor impingement and then psycho young athletes. You know, we had this one guy who was about 5'8", who's very active, very athletic, but he thinks he's going to be able to play D1 college basketball. So he's doing squat thrusts, all these different things, and he brings about a problem that we might not have seen for a very long period of time. And that's the nature of our current society. Maybe a problem for us. I don't think we're going to change anything with that, but that's what's keeping us busy with the hip quite a bit. When you look at the labrum, this is basically an extension of cartilage that goes from the very bottom all the way around to the other side. This is the transverse acetabular ligament on the very bottom. Okay? So the transverse acetabular ligament, nobody really knows what it does. It just sort of keeps the bottom of the horseshoe of the cup together, especially with development. I think that's probably when it's important. But either way, the labrum goes from roughly the 4:30 position on the clock to the 7:30 position on the clock all the way around. So that's just like this. Now the hard part about the labrum is that it's very highly innervated with nerve fibers, so it's very sensitive. So once it gets bruised, torn, or anything like that, that's when it becomes symptomatic. And when you look at the cross-section, when we cut this in half and we take a good look at it, you can see here's the ball right here. Here's the rim of the cup. This is cartilage in pink, and that extends into the labrum. You can see that over here. Ball, edge of cup, cartilage blending into labrum. These black squigglies are the blood supply. And so with orthopedics, the simplest way to think of things is where the blood supply is poor, that's your weakest section. So right here on the articular side right here is where we call the watershed zone. That's the area where the blood supply is not great. This is the area that's most vulnerable to injury. Unfortunately, when you tear your labrum, you're going to injure the cartilage on the edge of the cup here to some degree. And that's why a lot of people believe that a labral tear is the beginning of an arthritic process. Okay? And so that's why we like to intervene early. I do not operate to protect the joint. I do not operate to preserve the joint. I think that's a secondary benefit. I operate for symptoms. When people have the symptoms to justify the intervention, that's when we talk about surgery. This is my workhorse. It's called the anterior impingement maneuver. What you do, hip up, you adduct it a little bit across the midline, you internally rotate the foot. This is a little counterintuitive. You're bringing the foot out, but that's internally rotating the hip. And I scour it. Okay, so it's sort of an anterior impingement scour. I take them through that range of motion. In 100% of my patients that I operate on, I reproduce their pain, whether it's in the groin, whether it's in the thigh, whether it's in the butt, whether it's in the side. This is my workhorse. Okay, we have a paper that Andrea is working on talking about our diagnostic algorithm that we use to kind of decide which patients would benefit from the surgery. This is an awesome test. It should be part of every one of your screens for sports hernias, for hamstring tears, for lower back, well, maybe not lower back, but anything around the hip that you're worried about. This is just a wonderful screen to put in place. Now, it's not 100% specific, but it's at least something to keep in your mind. When you look at the labral tears, the majority of these are not one-time event. It's not like when you're skiing down that double black diamond chute in Vail and you twist your knee and you tear your ACL. This is something that, you're training for a marathon. I started developing some hip pain in May. June, it got progressively worse, yada, yada, yada. That's the way these things progress. And so it's rarely a one-time injury unless it's a car accident or a high-end injury where they could have subluxed their hip joint. Sometimes we'll see that. Almost all, and I'd say nearly 100%, have some element of femoral acetabular impingement. It's very rare to have a labral tear without impingement because I think the impingement chronically weakens the whole system and then eventually they tear their labrum. Symptoms, the classic location, people will say this, I hurt right in here. That's the C sign, okay? It's classically in the groin. It's also down the front of the thigh to the knee. It's also in the side. It's also in the buttock. Those are the 4 classic locations. It should never go past the knee, okay? If it does, you've got to think about the lower back. It's usually worsened with use, but people don't like sitting for long periods of time. They'll sit for a long period of time. They go to stand up. They feel like something's caught. They get stiff. They don't like to pivot or twist, but they're okay walking straight. But as soon as you ask them to change directions too much, they have a problem. So if you're trying to cool somebody off that has a symptomatic labral tear, sometimes just kind of getting them to work like a robot for a little bit sometimes can be very helpful. when you take a look at the MRI, we all look at this as our gold standard. This is the best way to diagnose it. I agree. It's the best way to visualize it. However, it's not quite as good as it's reported. It's reported to be sensitive in picking up about 90 to 95% of cases. But I do think it misses a lot of tears, particularly in our adolescent women or really, really flexible women. In that situation, we get wave signs, and I'll show that in the next slide. But if the point of this is if you get a negative MRI, particularly if it's a garbage MRI, an open MRI, a low Tesla magnet, when we have the measures of the magnets, you need to have a 1.5 Tesla or better. Some places have a 0.2 Tesla. It's garbage. You look at it, it's highly speckled. You can't really read it. And so if you have an MRI that says it's normal, really query that. Because if you think it's a labral tear, it probably is. You just need to prove it to yourself. When we look at the joint, what's this wave sign? So what happens is in really flexible people, they're kind of like a green branch. You can't break it, okay? And so instead of classically tearing the labrum right at the junction between the labrum and the capsule, what they do is they get this really hyper-flexible situation here. I'm going to click on this video one more time so you can see it. I think that should work. So what I'm doing is I'm pushing on the labrum here, and you can see the cartilage inside of it right through here is bouncing, okay? And so that's basically where the cartilage and labrum are injured together. Now the way I repair that is I basically will pass a suture through the cartilage labral junction and repair that whole thing to retighten it. I've learned with time, especially with doing the labral reconstructions, taking down the labrum, this is actually a very, very bad injury because it's almost better if you just tear the labrum completely. A lot of times with the wave sign, what you get is you get an intrasubstance delamination to the cartilage. And so this is probably a little bit more significant than we think. That being said, our repair technique, we have about 350 wave signs, I think, maybe almost 400. And this repair technique has worked very well. I don't like to put thermal treatment near it. Some people will thermally treat it. It stiffens it, makes it look pretty. But the problem is you're probably denaturing the cartilage to some degree, so I prefer the non-thermal treatment. This has worked very well for us. Labral preservation, this is absolutely the move. I think labral debridements are good in only a very small subset. We're learning through all the presentations and the guys that are able to do the basic science work that it makes a seal around the ball that keeps the joint fluid in the joint. Cartilage maintains or gets all of its nutrition through diffusion. So it gets it all through the sponge effect of compression, taking all the joint fluid in and out. We need that seal to maintain the fluid within the joint. And so that's very, very important for the cartilage life and health. Stability. It also increases the surface area of the cup, and it forms that tight seal around the ball that helps for stability. So what we find is when we distract the hip, and they did this study, they found that you didn't have to distract with that much force if the labrum was torn, where if it was still intact, it was harder to distract it. We also know from a cartilage protection standpoint that if you don't have a labrum, you're going to get increased cartilage wear with time. And I'm going to show that in the reconstruction set. What happens if you think about it, cartilage likes compression. It likes to be compressed. It does not like shear. That's why with ACL injuries, when we pivot, shift, and twist the knee out, we injure the cartilage because it doesn't like that shear force. When we have a ball in a cup, that edge of the cup, from the ball rotating in and out, is going to constantly see a shear force. That labrum serves as a bumper to diffuse that. That's not been proven yet. I'm sure that is something that's very important. That's just hard to scientifically prove. For me, this is my workhorse in the operating room. Virtually everybody gets a femoral osteoplasty. You can see this preoperative radiograph. This is a kid who's a hockey player. He had zero internal rotation because he had this giant door jamb in the very front of his joint, and he couldn't rotate against it. And so what we ended up doing is a femoral osteoplasty here, and you can see the difference in the level of satisfaction, VAS, pain score, Harris hip score, compared to where he started. This provides a couple things. Number one, we get a natural spherical femoral head-neck junction, which is helpful for the overall environment of the hip to protect the work that we're doing on the inside. But also, it creates a lot of bleeding in the joint, and that's helpful overall to get everything to heal. It also can compensate for a very subtle acetabular irregularity, because if you sometimes you don't always see the pincer as bad as it is, and so it can be helpful if you get the ball properly shaped. It can compensate for something in the cup that's just not perfect. So this is definitely my workhorse. Everybody gets this. when you take a look at this, so a lot of people come in, and Sean can vouch for this. Today we saw a bunch of people and they say, hey, I've got a labral tear. Do I have to fix this? Okay. In most situations, I say no. You don't have to fix anything. You fix it if it bothers you. Now, the hard part is when we get this type of a cam lesion. There was a paper that came out that said almost 100% of very severe cam lesions have a very high association of lateral cartilage full thickness injuries. And that's what you can see in this slide right here. You can see that we have a full thickness cartilage injury peeling off the edge of the cup right here. And so I'm a little bit more aggressive at telling somebody, you know, this is probably something that you should get fixed if it's pretty significant. Now, when you take a look at this, we get a lot of people come to us for second opinion if they've already had surgery. This was an open procedure. You can see the nice layout of anchors spaced pretty evenly through here. The problem with this is once you do it open, you pop out the ball, you're staring at it. It's hard to know exactly where to begin. And we do a ton of these. And so I say, do I start here with the femoral osteoplasty? Do I start here? Do I start here? I really don't know. I don't have an ability to check x-ray when I'm doing an open procedure. And sometimes you end up with this. This is a problem. I don't know what to tell patients with this. They have a very irregular femoral head-neck junction now that's highly unnatural. Now, are they going to have clearance? Sure, they're going to have clearance. But are they going to have too much clearance? I don't know. I prefer the natural approach. I think when you do it open, very easy to over-resect. When you take a look at this, this is the second part of the procedure. This is the acetabular rim trimming. What you can see is here we've burred the rim of the cup. We get some that are awful. So this is a massive pincer. This cup actually rotates around the ball. And you can see that pretty significant right here. So that's a pretty nasty, egregious pincer. Right here, we basically have resected them back to a lot. Now, the power of the labral reconstruction is we've actually been able to be very aggressive on the cup and get a lot more of the damaged cartilage resected and a lot more of the pincer resected. Labral repair, as you can see right here. This is my third portal. This helps me get a nice direct shot on the edge of the cup. And so that's why you'll see three portal technique for us. Microfracture procedure, don't have to do this too often, but sometimes we do. If you get a full thickness cartilage injury, unfortunately that cartilage is dead. So you've got to remove it. And then what we do is poke holes in the bone and we basically generate a blood clot in there. It's one of those things everybody's bummed about it, nobody wants it. At least in the short term, the results have been very similar. In some circumstances, they've been a little bit better. And I wonder if it's because we do the 6 weeks on crutches and we let everything really cool off for time. And so once you get through that 6 week mark, we do find that it is a little bit easier hip to rehab than somebody who just had a labral repair. Internal snapping, this is still a part of my arsenal. This is primarily in young women. The indication for me is painful snapping in the front of the joint. You have to differentiate this from IT band popping. IT band popping is if they stick out their hip in sort of a hula hoop direction, they can visibly pop the hip over the side of the trochanter. This classically is somebody who comes in and says, I can pop my hip out of joint. Well, it'd be very, very hard to pop your hip in and out of joint, but it's that dramatic of a clunk that it feels like it. And when I first got into practice, embarrassingly, at the old office, Valerie, I had somebody actually try and pop it out and take a picture, an x-ray like that, because I was like, there's no way this is. So yeah, I got fooled by it before, and it's okay. But now I know better. And so when you hear that kind of a story, just have them do that. If you feel it pop back and forth, that's the IT band. Classically, it's going to be in these really young girls with tight IT bands. They've always been able to do it. And then a lot of times when the hip becomes sick, it becomes more painful. And so we address it sometimes, sometimes we don't. For the psoas, though, if it's been painful for long enough and it happens several times per day, I do release the tendon. I release it where it joins the muscle. I'll show you that coming up. So I have not had any real weakness from that. When you take a look at the MRI, you can see why this occurs. So here's the ball. These are the axial cuts, so they're chops through the hip region. And what you can see here is here's the ball, here's the front of the cup right here, and here's the labrum. Right on the other side of the capsule is the iliopsoas tendon. You see that right here. So here's ball, here's front of the cup, here's labrum, and then there's the iliopsoas tendon right there. So this is a wacky muscle because it starts on your back, comes through the front of your pelvis, then goes to the back of your femur. So it has an S-shaped loop, and it basically glides over the front of the cup or over the front of the joint. Now, when the joint's inflamed, you have a speed bump. Okay? So what happens is that psoas that's co-contracting, because everybody who starts out with labral symptoms always has an iliopsoas tendonitis diagnosis at some point. So that gets tight. Now it's snapping over the front of the joint. Well, this is where the labrum's torn 100% of the time. So it's snapping over a strawberry and can get painful. And then that process cycles, and they get more and more problems. So what we end up doing is pretty easy. We make a little dime-sized window right where the psoas is. You can see how it's thickened right there, or maybe, I shouldn't say thickened, but you see the reflection of it on the other side of the capsule. And then basically what we do is we identify the tendon and we cut it. You know, Libby, the color is weird on this. It's yellow compared to this. Can you guys see okay? Does it make sense still? I don't know whether it's the lighting or what it is. And then here basically identify the tendon and cut it. Now the cool thing about this is we're not cutting it free from the bone. So this isn't a flail tendon now that's out in the breeze. It basically is a tendon that lengthens within the belly of the muscle. So it's a functional lengthening. So it basically accelerates the rehab. It makes your job a little bit easier now because instead of dealing with a super, super tight, painful psoas, a lot of times this releases a lot of the pain, releases a lot of the tightness, and kind of jump starts the system. I have 2 patients recently that have come to me, and at 6 weeks they have trouble actively lifting their leg. I don't fully understand that because I don't think that it's only psoas that does isolated hip flexion. I think there are other things that do that, but it may be that we partially stun the system for a little bit. If I put them in the figure 4 and do isolated testing of the psoas hip flexion like that, they do have some strength. So I don't think it's a problem. I've done this in some soccer players and occasionally a ballet dancer if my hands are really tied. I've not had any long-term weakness from this. But I also want to see some objective findings on the inside. I want to see some redness on the capsule. Now, to go to the Ganz, just to kind of give you an update on that, how we treat dysplasia. This all goes back to my philosophy. You can never just treat the labrum. If you just treat the labrum, you're going to have a problem again because your repair, your reconstruction, your debridement, whatever it is going to have a problem again because you have a joint that's not perfectly shaped for one another. In other words, bone and cup don't fit well together. And so in the situation where we have a shallow hip or a dysplastic hip, you have to address both. So what we do is we do a hip scope by me, we reshape the ball, and then I repair, debride, or reconstruct the labrum. And then we do the Ganz 5 to 6 weeks later, or we do it at the same time. Now, we're in the process of trying to decide what's better right now, and that's why we're gathering data. We're trying to decide if it's better to do it staged or if it's better to do it at the same time. I've talked with a couple of physical therapists who've had this. Most are saying they appreciate the fact that it was staged because they were able to get back 80% of the motion before we did that. The rationale there is if you do an intra-articular procedure, tibial plateau fracture, anything, you want to move the joint because it's going to get stiff. So if we do the hip scope and we do the Ganz at the same time, we're going to have a patient who's going to be laying around after the Ganz for a little bit. They're going to get a little bit more stiff. The one problem with a stiff joint is if you get a stiff joint, it's never really going to feel natural again. That's what we see with an arthrofibrotic knee. You'll get objectively a knee that moves pretty well, but it'll still feel stiff and not feel right. So that's why we stage them. Now, we've done a bunch together because the degree of dysplasia has been too bad. We've not had a problem with stiffness yet. So maybe it's overkill to do them apart. Now, when we look at somebody who has to do the 2 apart, that's a huge financial hit, social hit, anxiety, trepidation coming into the second surgery. If we do this in one, that would be my absolute preference. So we will see. Ron Hugate does the PAO. He's brilliant. Absolutely technically brilliant. He does a very, very nice job, and I'm amazed at what he's been able to do. Full recovery from this is 8 to 10 months. The whole progression from this, excuse me, it all makes sense. When you take a look at a shallow hip, you look at the edge of this cup is facing up. It's not flat the way it should be. This person is chronically edge loading, laterally subluxing the hip to some degree. You can see that here. This cup is upsloping. It is not flat at all. Okay? That's a bad biomechanical situation for the very edge of the cup. They overload the rim. Eventually what happens is they start to develop symptoms. They start laterally, then they move to the groin once they start to break down the labrum and cartilage. We want to intervene before the damage is too bad and try and delay the inevitable, which is an arthritic problem. This is what the Ganz is. It's amazing if you think about it conceptually because what you do is you functionally cut the cup free from the pelvis. You keep the pelvis intact the whole time. So you've not weakened the pelvis at all. You've just basically cut out a box which contains the cup and you rotate it over to a better biomechanical situation and fix it. It's so stable it only requires 3 screws to hold it in place, which is amazing. This procedure has been around forever. The results from Ganz, 25-year results in people who are dysplastic, 65% maintain their native hip joint. That's amazing. That's amazing. Now what I think we're making it better because they never addressed the intra-articular pathology. And I think addressing the labral tear and everything else is going to help some of the mechanical symptoms. This is why we do 2 procedures. This is why I get involved with a hip scope. Because if you were to do a Ganz, you say, well, why not just repair the labrum while you're in there? You know, you're there. Take a look at it. Well, it gets back to the femoral osteoplasty again. Femoral osteoplasty is hard to do with that mini open approach. Second reason is this is the view that you're going to get if you do that mini open approach. You're going to look at that labrum. That looks perfect to me. I think that looks awesome. Okay? So I'd say leave that alone. But look what happens when we distract that hip joint. Look at that labral tear. That's a garbage labrum. That's hypertrophic. It's torn extensively through there, and you have lateral cartilage. There's no way to distract the joint with an open procedure. So you're hamstrung. Your visualization is not as good. You're not magnifying this hip onto a big screen TV in high definition to make it absolutely perfect. And so I think there is the role for the hip scope. I think this is going to help. When you take a look at it, this is this gal. I never thought that this correction would get to this. And this is the one that Rod and I are very proud of because you could see this was doomed. This is awesome. The girl's 6 months out. She's back to work. She feels perfect. Her whole life, in my mind, has changed because biomechanically she's way more stable. We have 17 patients now with reasonable follow-up. This is a massive gain. I mean, this is almost 30 points on a 100-point scale for the Harris-Hip score. Look, extremity functional score, 22 points. Average VAS or pain score significantly down. Level of satisfaction is an 8 out of 10. So overall, this cohort is doing very well. We need a few more numbers to figure out whether we could do these together or not. But I think we're going to find that we can. Now this is how I simplify everything now, and I'm kind of getting the guys in the OR and Sean kind of understand my thought process. How do I treat the labrum? Okay, so when we take a look at this, you have a number of different scenarios. So if I have healthy labral tissue, good potential for healing, I do a labral repair. I still think that this is an excellent procedure. But if there's any question about the quality of the labrum, if it's severely degenerative, then we do a reconstruction. Okay? And reconstructing the labrum has been an awesome change. I'll show you the numbers shortly, but I've been very, very happy with the change. But a lot of it's based on if the tissue is unhealthy, my thought process is it may not heal completely. It's just been beat up for too long. And if you repair something that's unhealthy, if a very small segment of it doesn't heal, if it doesn't fully consolidate, it remains a little bit unstable. Unfortunately, once you operate on a labrum and it doesn't heal, it is more painful and more symptomatic and more catchy than it was before. First time surgery is a little bit better, so I've moved towards primary reconstructions more in those situations. Now, if I get in there, labrum's torn, and there's more arthritic wear in the joint than I expected based on the MRI and the X-ray, which happens a couple times, then we do a labral debridement. Now, the other situation for that is if the patient's over 60, physiologically I think the capacity to heal a labral repair or incorporate a labral reconstruction is a little bit lower. That's when a labral debridement's been a pretty good surgery. Now usually that's something that I'm against. I usually kind of speak out against labral debridements. I think it's absolutely the wrong thing to do in a 16, 20-year-old, 30-year-old, 40-year-old patient. I think you're going to have problems from it. But maybe as a temporizing solution, the recovery is very easy. It's more predictable. It's pretty straightforward. It might be a good situation. Every single one of these patients gets the impingement surgery. Again, if you don't treat the impingement, you're going to have a problem. So this is an example. This is actually a pentathlete who's an Olympic hopeful. You could see labral tear through here, healthy labral tissue. Okay, labral tear, healthy labral tissue. This is a repair. So 4-anchor labral repair, nice and anatomic on the rim, nice and stable, already, progressing nicely. This is a labral reconstruction. You get in there, and I don't know what you would repair. I mean, this just looks like a bomb went off in here. You're massively synovitic, labrum is shredded, and this is just garbage. Now, the cool thing about this, and this is why the labral reconstruction is so powerful, you can be very aggressive now. You could get rid of all the synovitis. You can burr back the rim of the cup to get to healthy cartilage, and you can make a new labrum. And so you look at this before and after, and I swear to God they're the same patients. This is a massive difference. Now they have a labrum that they can't feel, and I think this is a big difference. The role for labral debridement, I think that this is helpful in patients over 60, patients that think a total hip replacement is the worst idea in the world. I can't run on it. I can't play competitive tennis on it. I can't ski 200 days a year. These are the people that you kind of think about, and those are real patients that I was bringing up. So what I'm looking for is I'm trying to tease out, is this a mechanical problem? Is there a catch? Is it not the dull, achy, arthritic pain? Do they still have excellent motion? Does the joint still feel supple? Those are good things to look for, and then if that's the case, joint space looks awesome on X-rays and MRI. They don't want a total hip. You have to remove all the labrum, and I mean all of it. Don't leave any of it behind, because the labrum is basically, it's a circular fiber, and it goes, again, from 430 to 730 all the way around. All of its strength comes in these hoop fibers. So those are circular fibers. So if we say the labrum's torn through here and we take out a shark bite, That's fine and good, and we think, well, we're going to get away with that because labrum is attached to bone. It's not like meniscus that's free-floating in the knee, where if we take out a big shark bite of the meniscus, it's going to extrude, and with time it's going to be a problem again. The labrum is not inherently stable. These fibers here and here will come loose again. And we've had, John, you've seen this, we've had a couple patients who've had previous labral debridements. We get in there and they still have a big piece of labrum that's come loose with time. And so for me, I think that if you're going to remove it all. And then you've got to reshape the joint as well. So for me, when we have these patients come in, because we have a lot of people in Colorado that really don't want a total hip, they want to be active. And so Sean and I sit there and we try and decide with them, what's the best course of action for us? What should we do? Should we do a total hip replacement or should we do a hip scope? It all becomes pretty simple. I think if you make orthopedics complex, you're doing something wrong. Hip replacement is done for somebody who has no joint space. The range of motion is gone. Their joint is tight. It's non-supple. This seems more than just a mechanical catch in the joint. You look at the sagittal sequences of the MRI. This is my workhorse. So that's basically where you take cuts coming through like this, through the body. You can see the front and the back. Early arthritis is always on the front. So you'll see asymmetric narrowing of the anterior space. If that's narrowed, total hip replacement is going to be better. In this situation, cartilage loss is the main problem. That's the main problem for this patient group that's going to do well with a total hip. Hip scope, they've got a good joint space. They've got good motion. Internal rotation, obviously, is going to be a little bit down because that's what hurts. You're mashing against the labral tear. But the labrum's the problem. Okay, that's what hurts. The reason for surgery for me all the time is not a joint space. It's not a labral tear on MRI. It's patients who are not happy with their level of function and their level of pain. Okay, and that's the key. Does that make sense? Okay. So for the results for the labral debridement, we have about 26 patients. It's scary when you see this age group, 71. Please don't think I'm a nutbag and I'm operating on elderly people. This is a woman that walks 5 miles a day, walking because she hurt so bad. Her joint space looks like that of a 14-year-old. I had a long conversation with her family several times. We did an injection. She just didn't want a total hip. I didn't think she needed one. We did a hip scope. She's back to walking 5 miles. She was back to walking 5 miles at around 4 months. I've been very happy with the result. Was having no problem. So it wasn't easy to do, but I think it was the right thing to do for her. When you look at this, the results are stupendous. This is a 36-point jump on the Harris hip score. And that's actually one of our best jumps, is just a labral debridement. Pain score 5 to 2. Level of satisfaction 10. I've converted 1 at least to total hip replacement. I think, is that accurate? I think from the labral debridement, 1. So not perfect, but I think there is a role for it. Actually 2. The one patient got it twice. So it's the lupus lady. So she had lupus too, so that confounds things. But either way, I think this is a good procedure for the right patient. The question is longevity of the procedure, and that's what will be determined. Labral reconstruction, I think if you're young, your labrum was not healthy, it was garbage tissue, I think that it's better to do a labral reconstruction than it is to do a labral debridement. Time will tell for this, but I think the advantage is you get a graft that's going to protect that cartilage from that shear force that we talked about. Forms a nice seal with the ball, so we maintain our joint fluid, all those benefits that we talked about, and you can reproduce normal anatomy. If you look back historically through orthopedics, always our anatomic procedures are the ones that prevail. Our non-anatomic procedures are the ones that develop later problems. The more anatomic we can make our initial procedures, the more likely we're to be in a curative position. Now, this is what I was talking about for the bumper. When you see here, you can see the ball going into the cup. Here's the lateral acetabular cartilage right here. Okay, so as the ball rotates into the cup, this cartilage sees a tremendous shear force. So what do we do to protect that? Put in a labrum. Okay, that labrum will serve as a bumper to protect that lateral acetabular cartilage from that shear force. When you take a look here, this is the thing I was talking about with that other patient. You get in here, joint looks like garbage, okay, on the very edge. Labrum looks terrible, frayed, awful. I could put sutures around this, but it's not going to look good. It's probably not going to heal well. It's probably still going to be painful. When you take a look at the cartilage here, centrally, cartilage on the cup is perfect, but cartilage on the rim is damaged. Okay? This guy's got a massive amount of overcoverage on the cup. Burr it back, remove the labrum. Now we're clean. Look at this cartilage now. It's healthy. So we functionally have turned back the hands of time here because we get rid of the labrum. We can be more aggressive on the rim. We can remove arthritis in its early phase, which is really pretty cool. When you look back to this, we give all the credit to Dr. Philippon, who is our godfather. I owe a lot to him. He came up with this procedure. This was done as a salvage situation for people who have had previous surgeries. This was published in 2010 with 47 patients, 18-month follow-up. You're looking at a 23-point gain on the Harris hip score, pretty good level of satisfaction. Again, this is mostly done for revisions. This is a huge save for patients who have failed a previous hip scope. This is our evolution here. When I first started doing this in the spring of 2009, I actually tried to send a patient to Dr. Philippon, and it just didn't work out logistically and financially. And so I said to her, I haven't done it before, but I thought a lot about it, and I think I can do it. So if you're comfortable with me doing it, we could do it. And she was so desperate, she did it. And so it worked out great. And so I was really happy with it, and I was really pumped. I remember I talked to Ted when I got back up, and I was really excited, Valerie. It was a great night. And so that was the start of all this. And I remember I had actually a sheet, and I had like step 1 to 12 all written out. I had everything all planned out, but it worked out great. Now, in the beginning, I did the gold standard. I did the Dr. Philippon IT band autograft. Okay, so we take IT band from the side. I got up to about 27, and I had a couple patients, actually one that you knew pretty well, Brad, who started developing more severe pain on the lateral side of the hip than they did in the groin. And I started to realize that's a big problem. I mean, in women, you just can't mess with the IT band. In runners, you can't mess with the IT band. And so I started thinking about it more and more. And then we had a representative from Allosource who said, well, we do have IT band available as a cadaver graft. And I was like, well, I use it for ACLs. Why don't I just use it for the hip? If I use it for ACLs where we have a constant force between the tibia and femur for rotation and it's working, why wouldn't it work as a simple seal? And the one situation that we had for this, it was on December 30th, 2010. A big-time skier from Crested Butte came in, and we harvested his IT band. Had good bony work on both sides. It was a really heroic surgery. I think it was like 6 hours. It was really, really long. And we took out the IT band. And the problem with the IT band is you push on it on the outside. You think it's all uniform, and now you cut it out. Cut out your rectangle that you're going to need. You're kind of trying to be sparing. And we tubularized it, and it ended up being a cone. And so now I'm bummed because we've worked so hard, and now I'm not too happy with the graft. So we took a piece of allograft and did a pig in a blanket. And we ended up with a cylinder. It looked really good, and it worked really well. So then from then on, I just started using the allograft. Now, when we first started, nobody's been using this tissue, so this is all freeze-dried. And I think that's fine, but the closer you get towards a frozen, fresh sample, the more likely it is to be a better quality tissue. So we did about 128 of these. And then Allosource and MTS caught up, and they started giving us frozen grafts. And this was this spring. We're up to 105 now since this spring. So you can see, number one, we're doing a lot of work here. We're not playing golf. We're working hard. But the results have been so encouraging, this seems like the way to go. And as I've moved on with time, I've had a lower threshold to move to this because I don't have to stop the procedure. I don't have to harvest IT band. I don't have to worry about IT band symptoms afterwards. I just have a graft. And if the labrum is healthy, again, I repair it. If it's garbage tissue that I would debride, then instead of just getting rid of it, I make a new one. The other thing that you'll notice is we went from 4 to 5 centimeters in length to 8 to 11. Well, can you imagine what would happen if I took an 11 centimeter by 5 centimeter section of IT band out of a patient? That would be a disaster to rehabilitate. And so this is the huge benefit of the allograft. We have more tissue. We can make it thick. We can make 5 to 6 millimeter diameter grafts, which I couldn't make with autograft. And so it's been a very, very nice progression, and as a result of that, I have a lower threshold now to do that in primary situations for a couple of reasons. So when you look at the technique, our graft quality has improved, which we talked about. Our operative time has decreased significantly. I can now do we just did a 10 centimeter labral reconstruction with a ton of bony work on the ball and the cup in 3 hours. Now, we're not rushing, we're just efficient. We know our steps, we know when to start making the graft. Chris Irons, who makes the grafts for me, does a beautiful job. So we've got a nice streamlined system in the OR. We don't mess around. We have a fun time, but we don't mess around there. So it's nice and efficient. We don't have any donor site issues. Now, the other cool part about this is if you look at the blue arrows, that was my original reconstruction section. Okay, so I used to put a little anchor down here in the front because it was as low as I could go. You have to remember in the cup, it's not like you're staring in at this cup. You're working around the ball. You're working through a centimeter of space. It's pretty tight. So to get down this low is very hard to do. But the advantage, again, this goes back to my philosophy of the hoop fibers all the way around. If you disrupt from here to here, this is going to come loose with time, even if you have a suture around it. Because again, remember, everything in orthopedics, a fracture, a sutured piece of tissue, anything, it will fatigue fail with time if it doesn't heal. And so this sees a tremendous amount of stress. So what I've done now, is I've taken the graft all the way down to the bottom, down to the origin of the anterior transverse acetabular ligament, and I take it all the way back. Sometimes I've taken it all the way down to the bottom to reconstruct it as well. We've done a couple of total reconstructions. It all depends on the quality of the tissue back here. The nice thing is we work primarily in flexion, so we can get away with leaving some of the posterior labrum because we don't really work in extension that much, and that's worked very well for us. The key for this, the advantage of this, is we're not leaving any bad labrum on the bottom. So it is absolutely very, very rare for you to see a labral reconstruction that gets catching down the line. Now, this, we made a video, and I'm going to try and narrate it. I owe a lot to Andrea because she edited this. So it's got a cheesy introduction here, but it's, at least you know what's going on. So when you see here, this is a patient that we did a hip scope on. And now look at this labrum. It's stringy, it's nasty, it's red, inflamed. This is one that I get worried about. If you repair, you're going to have a problem with it down the line. It's going to be sore and painful. This is after we remove the labrum and burr back the cartilage in the rim. You can see we're all the way down to the origin and transverse acetabular ligament. Nice clean cup, beautiful cartilage on the ball. Functioning, all arthritis gone. Now we drill in one of the 6 anchors. This is basically, it's just like a molly bolt, except it has a suture built into it with an eyelet. And so we press that in. I use a material called PEEK. We use Linvatec anchors now, and one Smith & Nephew anchor. And that basically is a plastic that's bioinert, so the body's not going to react to it. Because the key with your anchor placement, you have to have it on the rim, right next to the cartilage. If you don't, you're not going to get your graft where you want it because the graft's going to go home. So that's why we put all of the anchors in first. So you can see all 6 of these anchors coming around, all nicely spaced and right on the rim. If you have something that's bioabsorbable, you're going to have a problem with it. Now what we've done is we've fixed the first suture to the graft and we just push the graft in. Okay, so this is all done arthroscopically through 3 incisions. We now have it laid out. This is the cool part. So you can see we're using the pulley to kind of cinch it down. So now it's cinched down in the very bottom with a suture that's fixed through the graft, and then we just progressively fix it from front to back, keeping appropriate tension on it as we work our way around. And so this is just tying one of the sutures down. But you can see, good looking graft, again about 5 to 6 millimeters in diameter, a really healthy tissue. Allosource and MTF have been providing us with, fortunately and unfortunately, really young donors, and so the quality of tissue, because we're the only ones kind of using this tissue right now, is excellent. And so hopefully we're establishing a VIP status so that this quality graft is always available to us. I'm really petitioning for that because I think it really makes a big difference. So now in the back, the benefit from working to front to back is that you can now cut excess away. And so if you fix front, then back, then fix in between, if your length isn't perfect, then sometimes you can have some bagginess to it. So this allows us to get the graft perfect. You can see goes now all the way down to the end. This is an instrument that's designed to push the suture through the graft so that now on the end we basically have a suture that's going to go through and around, and that prevents it from being able to slip out. So the graft can't slip out of our hold. But this is a really, really cool instrument. I've been happy with this. So now we're going to wrap it around. And then when you pull on the other suture, you can see that it'll pull it down in place. And it's probably about 2.5 hours of work, of boning work, or 2 hours to get everything clean like this. And the graft probably takes about 30 to 45 minutes, depending on how tight the space is to work in. This is a really generous space. This is why it became a video, because it was technically a little bit easier than some of the other ones. And you just want to kind of set that suture in a good spot so that you can tie it down. You can see how it cinches it right down, right into that corner. Absolutely nice and firmly adherent to the labral remnant just behind it. So this is definitely time-lapse photography. It doesn't go quite this quick. We have Andrea to thank for kind of trimming it up for us.
I think maybe I can take out a little bit of this part here.
No, it's okay. I think it's okay. I think it's okay. We're just getting impatient, I think. But that's basically the gist of it, to get it fixed in the very, very back. So we're looking upside down towards the back. Now you can see from front to back, you can see the labrum is nice and fixed. Each green suture represents a fixation point. We're compressing it against nice bleeding bone, which is prepared on the acetabulum. This is the best blood in the body. This is where we harvest stem cells. This is where we do bone graft for a non-union. and so this should incorporate very well. When you put the ball back into the cup, you can see an excellent seal on every aspect of the labral reconstruction of the femoral head. So again, to go back with our labral preservation ideas, we want to provide the seal to keep joint fluid in, seal to protect it with stability, and also that shear force. So that's the normal view that you're used to right up and down, and so that came out nicely. And so we'll see how she does, but I think that gives her an opportunity, whereas the repair she had before I think would probably fail. So this is the other thing that we've been doing a lot. So we actually have 49 patients, which is amazing. So we have some patients that you get in here, and if you think about it, we're doing a labral reconstruction for more advanced cases. So these are the ones that are really badly damaged. This is a situation where we've burred back the labrum, but now we have a hole in the cartilage. And so you can see where we're going to do a microfracture procedure. Now the philosophy is if we do a microfracture procedure here, we poke those holes in the bone. Remember, that's the way we do it. You need a blood clot. Blood clot needs to form. Blood clot then forms fibrocartilage. It differentiates into that. And so what you have in this situation now is if you make all those holes, you create that blood, what's to stop that blood from just eluting out of the joint? And so then maybe you'll get this little wispy fibrocartilage. You won't get this big, thick, meaty fill. So what we do then is we put a graft in there. And you can see now all the bleeding that occurred when we did the microfracture stays put. The results from this have been amazing, at least in the short term. I mean, we're looking at a 30-point improvement in our Harris hip score, huge improvement in the level of satisfaction and lower extremity functional score. So this is somebody that you'd say, well, we're kind of pushing our limits here, but at least in the short term, the results have been fantastic. When you look at our database, we're now up to 851 patients. We've probably done about 1,000 hip scopes total, but in the database, which started in July of 2009, we're up to 851. This is since July of 2009. Our last meeting, we're at 500. So we're on average now, I think we're on a pace to do about 450 per year. When you look at our ratios, more women than men, 2/3 to 1/3. Right side more involved than the left. Don't know if that's sport related or what it is, but that's just the way it goes. 6-month follow-up. The one limitation to our database now is we're very good at capturing the preoperative data, and so we don't miss a beat. Every preoperative patient, right before you go to surgery, I need to have your pre-op forms for how bad your pain is. That's the key for a database, because if you miss that, then it becomes retrospective and it's garbage. Okay. The post-operative, you can always gather. If you have let's say we want to review the Ganses. Well, Tara's going to help us. We're going to go out, phone calls, mailing, everything. We're going to get that cohort. We're going to get that follow-up as of tomorrow. And so we only have 543 that have come to the clinic with more than 6-month follow-up. I take that as a good thing, but we still are kind of in that lag phase where we have some more coming in soon. But on average, a 30-point improvement in Harris hip score, VAS score 5 to 2, so 2 is a very good score, 1 is 0 pain. Lower extremity functional score, 25-point improvement, level of satisfaction overall is a 9. These are very good results, something I'm very happy with. Word about the Harris hip score, this is what you have to remember. The Harris hip score is all based on the first question. How much pain do you have? None, or you ignore it, gets you 100. Slight, occasional, no compromise at all. That's a pretty good result. You're down to an 87. Mild. Uh-oh. I know how to fix that. I think I just have to go back, though. Oh, good. Perfect. And that means that somebody who's functioning pretty well, you're already down to a 77. Now, in school, I was used to kind of, I pushed myself to get good grades. I don't really like 87 and 77s, but that's just the reality of the scoring system. When you look at reconstructions, this is our database. So all reconstructions, autograft, allograft, freeze-dried, frozen, revisions, primaries, pretty good results, 52 to 79. Okay, that's almost 30 points, 5 to 2, 40 to 65, 8.4. So overall, for 260 patients, which is a huge cohort, remember that the original description is 47 patients, 260, that's not bad. Revision reconstructions, these are the ones that's a little bit hairier. Now, these are 55 patients. We still have an 18-point improvement, not bad. But our scores aren't quite as good. We're about 23 points on the lower extremity functional score, which is still pretty good. Level of satisfaction is still pretty good. I think that our reconstructions, so in other words, our attempt at a labral repair that didn't work to a reconstruction, those do well. Those do well. But you got to remember in this, I get a lot of patients that come from random places that have had an open hip dislocation and then an arthroscopic labral debridement, and then they come to us for a labral reconstruction. That's a tougher patient to get well, and I think that's where the numbers come down a little bit. Primary reconstructions already, you can see, back to our normal numbers, back to a very nice 32-point improvement, very nice uniform results. Allograft reconstructions, some of these allografts include revisions, so that's why we're a little bit lower here, I think. But overall, these are favorable results in a very large cohort of patients. We're particularly interested in the primary reconstructions that are allograft. That's what Andrea and I are working on right now. We're hoping to have a paper out by February. February is the goal. So we'll see. It's just a question of when all the numbers work out. So failures of hip arthroscopy, this is what I don't like. Conversion to a labral reconstruction from a repair, 32 of my patients. Now, the majority of these are women in the 40-plus age group, so I repaired something that was degenerative. I went through a phase where I thought that was better. Debulk the labrum and repair it. We still got some good results from that, but I think overall it's better just to reconstruct it primarily now because 32 is a little bit too high out of 850 for me right now. I don't like that. Conversion to total hip replacement, 8 patients. The majority were more advanced wear than we expected on the inside. So that's an overall failure rate of 4%. I think doing more primary labral reconstructions has allowed us to win on patients that you wouldn't expect wins in. So I think it's a procedure that's here to stay. Again, when we look at our overall database comparing the labral repair to the reconstruction, our numbers are very similar. Now the thing you have to remember that's impressive is that if we do a primary labral reconstruction, we didn't do it because you had healthy labral tissue. We didn't do it because you had a healthy joint. We did it because your joint was shot. So if we can get similar results in that patient who's worse from the start, that points to the power of this procedure. I also think that the first surgery presents us with our best opportunity to get a perfect result, and that's what we go for. And that's why we've been moving towards that. And that kind of supports my lower threshold to move to primary labral reconstructions. Our clinic for Sean and I is much easier now that we do more reconstructions than we did more repairs. They do better faster, for sure. This is my prediction. People may think I'm crazy for this, but I think right now we're currently fixing ACLs with rare exceptions. I think if the labrum is healthy, you can do well with the repair. If the labrum is not healthy, trying to repair it is just like trying to fix an ACL 20 years ago. These need to be reconstructed, especially in patients more than 40. When you take a look at this picture, this is a cam lesion. So this took this guy almost 30 years to develop this giant crevasse in the front of his femur, okay? Well, the thing that's been right there as a primary focus has been the labrum. How can that tissue possibly be healthy? I just don't think it can. And so, to me, I think that if this is bad when you get in there, just move forward with the reconstruction. I also think that the hip or the acetabulum provides you with an opportunity to have an excellent environment for incorporation of the graft, good blood, high-quality pluripotential cells, very good potential for incorporation. The other thing is that you get all the benefits of a labrum, but it can't be painful. This is a graft that will never be innervated. It will never be painful. And that's a huge advantage down the line. I think also the rehabilitation is easier and it's more predictable. When you look at the rehab in general, I've snuck in an extra week on you guys with regard to crutches. 4 weeks is now my standard. I used to do 3. I used to do 2. The more I do, the easier it is just to keep the joint cool, progress everything later. Labral reconstruction, again, is 4 weeks. Microfracture goes up to 6. I reduce the weight bearing a little bit through that. I never go non-weight bearing on hip, ever, ever, ever. As soon as you start hiking the hip and going in a non-weight bearing situation, you're in isolated hip flexor contraction. So you're hurting yourself by doing that. The other thing is you're increasing the joint reactive force across the joint by non-weight bearing because your glutes are pulling that hard to keep you up. External rotation to neutral only for 2 weeks. I don't want to externally rotate too much. That's why we use those obnoxious boots, which I don't like, but we have to use for now. And that's just to protect the capsule. So that's the capsular closure part. The main goal in the beginning, just get your range of motion back, get your core back, go very slow with the hip flexors. Return to sports about 6 months. This is not a race. This is a marathon. Don't burn out early. Just take your time. You'll get there. As long as you don't flare the hip as you move forward, I think that you'll be very good. As always, I always preach, don't follow the bubble sheet. Don't follow the protocol. Follow your patient. If you have somebody who just wants to do the elliptical, they've got no business doing box squats and lateral jumps and sports tests and all these. Just look at who you're treating and give them what they need. If you have painful physical therapy, so you're just not making any gain, go in a cold pool. Put them in a pool for a while. Let them just do some walking, side, backwards, forwards. Get the glutes activated in a lower gravity environment. That's very, very helpful. It's especially helpful in our lower demand patients. It's especially very helpful in somebody who starts off with a hip that's very, 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 very painful. Always in the end, we get people signing out of physical therapy at 2 or 3 months and saying we're done, even in some of our athletes. I don't really like that. I think once you get to the 6-month period, let's take advantage of this time. Let's take our girls that have horrible mechanics. Let's work on jump mechanics. Let's work on their core stability. Let's take advantage of this situation so they don't get an ACL. Let's put a program forward that they can do every single day as part of their workup to make them stronger and safer so that they can do their sport better and not get injured again. What I've learned is there's no benefit in going too fast. If you prematurely return to exercise, you're going to get into trouble. Not every hip rehabilitates the same. Everybody is completely different. So just because George did it this way and he did great, forget about that with Martha. They're all different, okay? As long as you never flare the hip, you take your time, you're not going to have a problem. If you start getting these flares, we have to go on crutches, we have to slow it. Just try and stay away from it. Be very careful with the hip. It's very dishonest. You will do an exercise that you think is absolutely appropriate. You'll get awesome feedback in the clinic. They'll say, man, I'm awesome. I feel great. I got a good sweat today. This was great. And then they'll go home and they'll hurt for 3 days. Okay? Or you'll do it for 2 or 3 days and then they'll hurt over the weekend. So take your time with this. Try something new. Make sure it works for a week or two before you push it too hard. Always, if you get an opportunity to know the patient beforehand, a lot of times their preoperative severity of symptoms, and that's especially pertinent for that patient who was at Blue Sky recently. That patient had terrible pain before he was on crutches. She had a hard time getting back, and I think a lot of it had to do with where she was in the beginning. With reconstructions, the joint motion comes back faster. Pinching in the front is gone faster, more predictable recovery. I'm seeing patients that feel perfect at 2 months. And there's no way I get that with the repair. But again, if the tissue's healthy, I still prefer to do the repairs. That's still important. They're still prone to hip flexor tendonitis, though, so you have to be careful. For me, hip flexor tendonitis has become relatively simple in my understanding. I don't know that it's all hip flexor. I just think it's a muscular imbalance of the hip. So I think of the hip in 4 quadrants: adductors, hip flexors, glute med, mid, and glute max. So 4 categories, okay? For some reason, I don't know what it is, the glute med is shut down even before we operate, and when we operate, it gets even worse. So the glute med shuts down, everything carries the load. Your hip flexor has a baseline tendonitis or dysfunction in the beginning anyway with your iliopsoas and your hip flexor complex. So that overworks and you end up with a problem. And usually what happens is it's all non-compliance. Somebody is doing way too much because they feel too good. And that's one problem with the procedure. If you get it, recognize it early, slow it down, put them on crutches, anti-inflammatories, get them in a pool, start backtracking, okay? Because the problem is even if you get better, they flare again. So these are my 2 kids now. I couldn't believe this because what I try and do with these talks every year is I try and take the last talk, delete half the slides, and build a new talk. And so last time Charlie was a little baby, and so, well, maybe not a baby, he was a young boy. But now you can see he's got his ski sweater on, and a very provocative pose for a 2.5-year-old. I would never say that about my daughter Ann, but I got to keep my eyes on these kids. So it's amazing. It's been this long since we did another talk. You always kind of realize how fast life is going when you see your kids grow up. And I'm just very grateful with the addition of Sean and everybody who's helping me with our system getting more efficient here at PSL. I'm spending more and more time with my kids, and I'm very grateful for that. At this point, I want to introduce Joe. Joe is somebody that I've always had a lot of respect for. You know, he's got a very concrete mind. He's always thinking about things, and if I have a tough patient, I really like to send him to Joe just to try and get back on a good track. And so Joe had the opportunity to go through this hip surgery. He had a surprisingly pretty rotten joint on the inside, and we debated what to do for a little bit, but you could see chronic bruising of the labrum here, very diminutive and small, some cartilage injury to the edge, and so we ended up doing a reconstruction on him. He's now 5 months, Joe, so he's moved back to Vail, unfortunately, but still reachable. It's not that far away. He's agreed to kind of chronicle his first 5 months, kind of give us some insight as to what he experienced, how it's different, and I just think I really appreciate him coming down to do this for us tonight, and I hope that you guys find it helpful because this is really for you. Thank you very much. Question?
Yeah.
Here you go, Joe.
Going back to the weight sign and with young women that are pretty flexible and seems to be a more common problem that they have a negative MRI. How would
Yes.
you diagnose that without the arthroscopic?
Oh, perfect. I'm glad you reminded me. Actually, so Sean's been working with me now for a little bit, and so I always kind of ask him, you know, hey, so what do you want to do here? What do you want to do here? What do you want to do here? And a lot of times my answer is diagnostic injection, because the hip lives in tiger country. You've got hernia issues, OBGYN issues. We've even had one guy who had testicular issues, lower back issues. Everything all kind of crosses through that region. And so for me, we kind of have 5 things, and this is the other thing Andrea and I are working on right now. So we have 5 things that we look at. One is the history. Does it smell like a labral problem? You know, does all these things start to sound alike? Do we reproduce some of their pain with the anterior impingement maneuver? X-rays, do they have impingement in a preserved joint space? MRI, do they have a labral tear or not? Okay, but that's the one that sometimes isn't always there. The last thing we do is we do a diagnostic injection. Now, there are a lot of ways to do it. A lot of people will, when you get your MRI, throw some cortisone in, throw some lidocaine or marcaine in, and do your MRI, and then see if that makes a difference. I tried that for a little bit because I thought that was a smart idea. The problem with that is that you inject so much dye into the joint that from a pressure standpoint, you create pain. And so sometimes lidocaine and marcaine can offset that. When we do it, we just do marcaine and lidocaine. I could do it myself, but I probably would miss 10% of the time, and if we're making a surgical decision, I don't think it's safe. So I send them to one person at Touchstone Imaging, and she's brilliant. Tina, she's brilliant. And so usually it should be a painless, relatively painless experience for the needle. It gives the patient 2 or 3 hours. So they run around on it, they twist on it, they do the anterior impingement maneuver, they tell us what goes away. And then from that, we use that as an objective mark. So typically what we'll see in those patients who have the wave sign is they're able to run around, they feel great for 2 or 3 hours, and then the injection wears off and they hurt like heck for a full day because they did things that they haven't been doing for a while. And so that's a positive response to the diagnostic injection. That's how we get those patients to determine that this is going to be a helpful procedure. I'm sorry I forgot that. Thank you. Okay? All right, so I'll turn it over to Joe. Here, Joe, you got to do this.
I just need that one, unless you're videotaping me as well.
No, yeah, we're going to videotape.
Research I did along the way because these things were interesting, or I had some issues and I wasn't really understanding what was going on. And then I'll go through some of those symptoms and kind of how I look at those when patients come in with those symptoms that I had. So 31-year-old male, chief complaint was glute pain with sitting. So I never had any pain with activity. I could go run, I could go snowboard all weekend. I would just pay for it the following day. So if I went snowboarding on a Sunday, Monday was going to be a rough day at work because I don't sit that much, so it wasn't a big deal. I had pain for about 2 years, and it just progressively got worse. I could go from sitting, I couldn't even make it to work in my car, which is about a 3.5 mile drive, and I would get pain immediately from sitting in the car. I had no pain with impingement activity, so when I went in to see Dr. White the first time, he did an impingement test on me, and so nothing happened really. So I was one of those cases that really didn't follow his algorithm. So we did an MRI, and that confirmed that I did have a labral tear, but he was still a little apprehensive because of where my symptoms were at, and that was in my glute. So we did a diagnostic injection to confirm, and that pretty much took care of all my pain with that. And that lasted for about 4 hours, and so I did some things that day that I probably wouldn't normally do, and I didn't have any pain when I did them. Pre-surgery symptoms, I had poor glute complex and endurance. So if I were to do a workout, especially like single leg lunges or squats, I could not do the same amount of reps on one side versus the other. So my right side was my surgical side. I had quite a bit of glute complex atrophy. I noticed this one morning getting ready for work. I noticed I had a large divot on the right side of my hip compared to my left, and that was where my glute med used to be, and it really wasn't there much anymore. And just the good old field test. Faber was increased on the right. I don't know if y'all are familiar with using the Faber. As far as a Faber for your lower back, Dr. Philippon uses the Faber as a screening test that is indicative of labral tear. They usually measure from the table when you're laying supine the difference. And if you usually have a 5 centimeter difference, then it's indicative of a labral tear. I don't think that it's the labral tear that actually causes this. I think it's the pain or the compensation from your adductors and the TFL. So I did have a lot of hypertrophy of my adductors and the TFL. And then I had a slight antalgic gait, and that was increased pelvic sway. So when I would walk, my pelvis would rock anteriorly. So that was mainly my preoperative symptoms. Post-surgery symptoms, just overall soreness, hip flexor pain and tightness. I never had any anterior pain, so I didn't really know what that was until I had that surgery and I had to get out of bed the first day, and that did not feel great. And so your hip just feels really full. Going along, I had, again, adductor and TFL compensation. I was very tight in my external rotators and abduction muscles, and then I had difficulty with glute control and pain. So the first day that I tried to do an isometric in my glute, I couldn't even do it because of so much pressure and pain anteriorly. So be careful with that with your patients. Not a lot of people have that, and they don't need to do a glute maximal contraction. You just want them to have it cut on and cut off. And then a lot of hamstring tightness because my glute did not want to help me extend past neutral for the first couple of weeks. So going into your patients and when you get your history or they come to you either pre-operatively or post-operatively, is definitely look at age. And we know that adolescent females tend to be the ones that have the most issue with this. And so go slow with them. Sex again. Males usually do really well with this surgery. They don't really have any complications. They can. I think mainly males probably underreport because they don't want you to know how much pain they are in some cases. So be careful with that. Pre-surgery pain and location. So when I first interview a patient, I always ask them, what was your pain previous to surgery and where was it at? And where did it start? So did it start more laterally and move anteriorly, or did it start in their glute and move more laterally? Just kind of those symptoms, because with those patients, you want to pay attention when you're progressing their exercise routine, especially with your repairs. Are you reproducing their previous symptoms? Because that's going to be very discouraging for your patients if they start to get that little bit of pain back in that area. People with posterior pain, I feel, progress a lot faster because they're anterior. They never had it, so they're not really apprehensive about things. And then the cause of their pain. Did they only have pain during running? If that was the case, then they're probably going to progress pretty fast. If there was somebody that they couldn't sit more than 15 minutes or a long day at the office or whatever, so just know how susceptible and how sensitive they were. And then length of signs and symptoms. So are they less than 6 months, greater than 2 years, that kind of thing, and then an articular lesion. So a lot of the times Dr. White does a really good job of drawing on the back, a nice illustration for his patients. I tend to look at those and see where there may have been some chondral wearing or on the articular surface of the femur, because there are some studies out there that show that people with articular lesions, whatever grade they meet from 1 to 4, they progress a lot slower. Most all people do have some type of articular lesion, but if it's a 3 or something, just keep that in mind. The number of surgeries, of course, if this is their 4th or 3rd hip surgery, and Dr. White's just done a reconstruction on them, they're going to have a lot of compensation patterns that are going to take a long time for you to maybe pick up on, but just assume that anything that can go wrong will probably go wrong with them at some point in time, whether it's core weakness, glute weakness, compensation in muscles that you're not accustomed to seeing. And then, of course, repair versus reconstruction. The repairs, they're going to let you know if they're painful. The reconstructions won't. Just like Dr. White said, at 2 months, they're feeling really good, and they're going to try to test it and do some things, but we don't know how well this reincorporates. We know with the repair, based on some ovine studies that Dr. Philippon did, that about 12 weeks, the repairs are, if nothing goes wrong, that they're about 80 to 90% healed. Reconstructions, we don't know if ever or how much it does reincorporate and what rate, so just keep that in mind. There was a study just released out of Australia. I just got it today. A guy did 6 revisions, but he putting in total hips, and he did a histology sectioning of the labrum, and the labrum at 10 months is really well healed. The problem with those patients is they had a microfracture, and the microfracture just didn't take, and because of age, they were in that 58, 65-year-old range. So just keep that in mind. Looking at length of signs and symptoms, there was this paper that I found, and we see A, B, and C here is kind of how they divided up the cohort. A was anything less than 6 months, B was anything from greater than 6 months to 2 years, and then C is anything greater than 2 years on to 3 years. So we have pretty much where all our patients fall is in category B. We usually see people at right about the 2-year mark. And so they're pretty evenly distributed, more females and males in the overall thing. And then not many of them had chondral lesions, and then almost of them all had a labral tear, or was identified with a labral tear. And then this is their the study with their the Harris hip score, and you can see the p-value here. As far as the groups, they're pretty similar, except when you get down here to preoperative, postoperative, as you follow that on. And you can see that the p-values way down there at the bottom for 2 years, which is A versus B, they're relatively the same. You wouldn't statistically think that those are that different. But when you get into the group A versus C or B versus C, there's a pretty significant difference in how those people play out over 2 to 3 years, which goes on to what Dr. White's doing. These people in group C were probably better candidates for reconstruction. So just keep that in mind, that if you have somebody that's 3 or 4 years out, that they may not get where they want to be, especially with our active population. So just keep that in mind. And then this was the revision rate. Of course, in A, they had less than 4%, which is where kind of Dr. White falls. And then groups B and C were up around 10 and 14. So just keep that in mind. So phase 1 is after surgery. It's pretty much the same as it always is. Protect the surgery, decrease inflammation and swelling, restore range of motion within limits with circumduction, and muscle re-education and control. And then phase 1 problems. Most people get out of phase 1 with no issues. This is pretty much, they're just moving along. You're trying to get them to where they can wean off crutches at 4 weeks. Main things is glute and iliopsoas inhibition, tight external rotators, hip flexor pain, tight hip extension, and a pinch in the joint. Not everybody has a pinch, but the most cautionary one I would tell you is the pinch in the joint, because that really discourages a lot of people and they get scared of it because that was their prime symptom before. But just assure them that, Dr. White was in there for 4 hours banging on the front of your joint, so it's going to be a little bruised for a little bit. But that'll calm down in a couple weeks. And then tight ER muscles. I didn't really give this a whole lot of thought before I had surgery. I would work on a little bit of internal rotation, but I was never really concerned with internal rotation because it always came back, and it usually comes back better because he takes a large section out of their femoral neck junction, and so they have better internal rotation usually on their surgical side. But your external rotators get really tight, and a lot of the times I think that's the problem with progressing patients is they're so tight that they're not functioning properly, so the adductors, the TFL, and some other muscles that we'll look at end up taking up a lot of the slack. So phase 2 or flare-up central. This is kind of the phase that if you get out of, you're probably going to be fine. If you get them to phase 3 and you start to do, running or whatever high-level activity it is that they want to do, then you're probably safe. But phase 2 is where I think most of the people, we never get out. They're either 4 weeks to 12 weeks or it's forever. You've been treating them for 16 weeks and nothing has changed. You're doing the same exercises and you're running out of things to try with that patient. So just be careful in this phase. Normalize gait, restore full range of motion, neuromuscular control, proprioception, and then functional exercises. Phase 2 problems. Adductor pain, medial glute fold pain, anterior hip just pain, so if you kind of come up a little bit more laterally, gait issues, and then that mini joint flare or effusion that it's hard to detect because there's no way to do a sweep test or any test that you can do for the knee or the ankle that you can obviously see that there's a lot of swelling or effusion in those joints. So adductor and TFL hypertrophy is a lot of what we see, and I think it's compensation due to iliopsoas weakness and pain, plus poor glute complex control. So there's not really too many EMG studies out here that deal with this, and then the few that are, Dr. Philippon did one, and he just looked at basic exercises and not gait or anything like that. And then you have the in vivo prosthesis studies with hip, and it looks at weight bearing and non-weight bearing, and those are really good studies for weight bearing, but they don't really show us any exercises. The couple of exercises they do aren't tested in any reality that we would actually ever use. Hence the one that has you lay in side lying and tests your abduction and says press as hard as you can. I don't think I've ever had anybody do that exercise. We do maybe a little bit of active abduction to get the glute med, but you would never press that hard. So they looked at that. So I found this study. I did a lot of looking and trying to find a study that would kind of back up what I was already thinking. And so Kara, whoever she is, they did a 3D model study, and what they did is they took some EMG data from 6 patients just to get some normalized EMG, and then they plugged it into a 3D model. And so they did one exercise that we will never do, which is a straight leg raise. And they, all these muscles are displayed of the forces they did. But what they did in this study was they took the iliopsoas at what it was at a normal, say 100%, and then they cut it down to 50%, 25%, and then 5% of its total force that it could produce. And so when you did that, if you look at supine hip flexion on the right and then prone extension, we'll talk about that in a minute, you can see that the total force starting at 10 degrees of extension going into 30 degrees of flexion, so they kind of were hanging off the edge of the table, it's increasing at that most neutral point is kind of the high, and then here's how much not distraction, but compression within the joint, and then anterior forces, and then nothing really happened immediately. So I didn't think that was all that irregular of what I thought it would find. I'm like, yeah, you do a straight leg raise, you're going to cause a lot more joint force. And so no big deal, I'm never going to do that exercise. And then in prone hip extension, it was kind of the opposite of that. So they took the glute, found the EMG data, and then they did the same thing, cut it by 50, 25, and then 5% of what it totally could do. And can't really see it well, but the black line is the normal, blue line is, this one is the without the glute, and then the other one on the other side is they took the hamstring out as well. And so, didn't really tell me anything I didn't already know. Other than in those instances, when you start to decrease, you actually increase the amount of force at neutral. So if you look at hip neutral, 58.1% increase in over normative force with decreased iliopsoas. So you're causing a lot more force in the anterior portion of the hip, which is a problem when you're trying to get a labrum to heal or we're worried about hip flexor tendonitis. And then if you did it in hip neutral and they took the rectus, the TFL, and the sartorius out, you only had a 6.8% increase. And I think our big problem is when he does the surgery, the hip flexor is just collateral damage. It's just in the way. You can't do anything about it to really protect it, and so it gets super irritated. So when you see those patients that come to you as they're weaning off crutches or they did too much walking and they're like, well, my adductor hurts, or they're pointing to kind of their pubic symphysis or their gluteal fold, it's probably because these areas, they're overusing those three muscles to do everything. So what they looked at, and we'll kind of go past this part because I've already studied. So here's the compensation patterns that they got. So condition 1 versus condition 4. So condition 1 is the normal forces. So if you look at prone hip extension, the semimembranosus, TFL, and the sartorius don't really do a whole lot in extension. But then you take the glute out and you decrease it, and we can only do 5% of what it's supposed to do. You see that your semimembranosus, your TFL, and your sartorius increase by a factor of almost 100%, which is almost theoretically impossible. And then you do the same thing in hip flexion, and then you see the TFL, the sartorius, and the adductor, relatively small, just stabilizers like you'd expect them to be. And then you come over here to condition 4, and they've almost doubled or tripled in value. So they're doing something they're not intended to do, plus they're creating shear because they're not moving the joint in their traditional just single plane. So it kind of led me to say, okay, this is going to be an issue, but what implications does this have? So if you look at somebody that's walking, they spend about 60% of their time in a stance phase and 40% of the time in swing phase. But then when you start to speed that patient up and get them into running or sprinting, then it goes the other way. And so you go from almost 55% of swing to 45% stance, all the way up to Olympic sprinters where they're doing 80% of swing and 20% of stance phase. So when you get to your running progressions and your person goes out and they said, oh, it felt kind of great, they do it 2 or 3 times and they come back with all this adductor pain, this may be your problem because we don't really ever address the hip flexor to do that much repetitive motion. And so that, I think, is a problem that is occurring, and me and Dr. White have talked about this, is does hip flexor tendonitis exist in the capacity that we think it does? We think it's that irritation of the hip flexor to the anterior portion of the joint, because some of the diagnostic injections he does later on, the pain goes away, so it's probably not the hip flexor. But I think the hip flexor does have to be strengthened at a point, but when and where and how much is still yet to be determined. So this is just looking, this again, when they cut the hamstring down as far as 50%, you can see that they're relatively the same. So we need both of these. So don't neglect one trying to get the other. And so you need to work on those. But when your glute is weak, you'll have that person that comes in later down the road and they say, it hurts right here. And you're like, well, why does it hurt right there? Well, we know that that's where that portion of the hamstring that's trying to help you extend connects at. And so that may be an area to address. And here, hip pain or a pinch in the joint. So their pinch kind of cleared up for a little bit, and then all of a sudden it comes back. These are the kind of my thinking of what contributes to that. Is it the sartorius, is it the pectineus, iliopsoas, or is it the capsule? It's usually one of those 4. So we're going to kind of go how I tease those out as far as that's concerned. So I don't know how many of you use quadruped rocking to help restore range of motion. It's something that we do quite often. So I usually stick a person in quadruped rocking and have them do 10 reps and see if the pinch is there. If the pinch is not there, then I'm like, good, it's probably not that flared up. If it is there, then I'm thinking that it is really flared up, because usually when you put them in weight bearing and you have them move around, it puts the joint in a proper spot, and maybe something was just moving wrong. So if that's pinchy, then I put them on their back and I test hip flexion. Well, hip flexion is always pinchy. But when I do test hip flexion, I do it eccentrically. So I have them push into me, and then I load it as far as they'll let me go, and I tell me when they have the pinch, and I compare the two. If the pinch goes away, then more than likely I'm thinking that it's soft tissue, and it's probably either sartorius or your rectus or potentially iliopsoas. And then testing extension as well, and testing the quality extension passively. So can you extend the left or the right or the uninvolved and the involved, and do they feel like they go symmetrically, or does one of them feel kind of sticky, like it doesn't want to move in that direction? And so that can kind of let you know, is it capsule or iliopsoas, because they usually don't have any problem in their sartorius or the pectineus with hip extension. It's one of the larger groups, which is usually your iliopsoas or the capsule. And then again, I use modified Faber a lot. So this one it's similar to the Faber. I just don't put their knee on their foot on their knee. And so I have them go into that position and drop out and kind of comparatively look at and see if they get full range of motion, and do they have any catching, and where is that catching at? Sometimes they'll point right to their adductor, so you assume their adductor, or they'll point up high to their kind of TFL area, and that'll let me know that it probably could be somewhere around their pectineus, and it's just tight, and it's creating the joint, and it's pushing it up. And so I use that a lot in my daily treating. I check it and see, well, how does this feel compared to yesterday? And then palpation, I use this quite a bit, especially with the iliopsoas. It gets bunched up a lot of the time, and so palpating and comparative to see how sensitive it is. I'm sure we've all felt that muscle that has that hot spot or trigger point, and that's kind of what I'm looking for. So either the iliopsoas isn't working all that well, and so you'll test it there, and you just won't feel anything. So I put them in, the 90-90 hip flexion, palpate, have them give me a little resistance. Do I feel anything? I also palpate at the same time as where the rectus and the sartorius come up, because they kind of overlap. And I'll put 1 finger or 3 fingers on the iliopsoas and 2 fingers on the sartorius and the rectus, and you'll feel a very big difference, especially if it's overdeveloped or hypertrophy. And then you check the other side, and then you let the patient feel, and they'll notice, wow, this does not feel. And so that's a lot of the time what that pinch can be. It's just rolling up in the spot of where the ASIS and the front of your leg meet. It's kind of like having a big shirt on and then trying to bend your arm. It just doesn't want to go there, and it's not that there's anything going on with the labrum. And then piriformis stretch, where you have them kind of in this position. I'll actually take them into that position and see where they feel it at. Do they feel it more anteriorly, which is not normal, or do they feel it posteriorly where I expect them to? If they don't feel it more if they feel it more anteriorly, I'm going to put a little bit of compression on them and see if it moves to their glute. If it moves to their glute, I just think that everything anteriorly is really tight, or they don't have a very good glute complex to keep everything where it needs to be. And so I'm going to address those areas. And how am I going to address those areas? That's kind of up to you to decide. If they're far enough out and you feel comfortable enough with dry needling, then maybe that's something you should do. Soft tissue, or they may be so sensitive that sometimes you just have to stick an ionto patch on them, and hopefully it just calms down in that origin portion, because it is so tender and sensitive. And then another one is the posterior deep rotators. How I usually test this is I have them lay on their involved side, and I just have them externally rotate their foot. But what I do is I make them do a set of 30, and then I have them test the other side. In most cases, they're going to be able to do about 10. And that's just because we don't work on those, or something happens and they get flared up and they stop working. I think that's one of the things that we kind of neglect a lot of the time. But what they'll try to do is they'll actually, if they're laying on the plinth like this, is they'll lift their leg up and recruit their adductors. So you have to watch out for that, because they'll do the first 5, and then the second 5, their leg will be off the table. And so posterior deep rotators, I think, are one of those things that just is kind of like the cuff. You have to do low load, high rep just to get them stronger. And then the last one is TA control. A lot of the times we kind of overlook it, or we work on it the first couple weeks, and they're like, oh yeah, I can do this all day long. And so you assume that they're still doing it, and then you go back and check at 6 to 8 weeks, and it's not even working, and you're like, what have you been using to do all these exercises at the beginning? Their obliques and their rectus abdominis are probably tender to the touch because they've overused them so much. And so moving on, so where do we go from here? So we've got some good information as far as what does the hip flexor do. I don't think anybody doubts that we should continue to do posterior chain stuff. And then when do we start that hip flexor strengthening? I think that is something that I've seen with more of my higher level patients down the road is we didn't really ever address this, and maybe that's the problem with the adductor and all the compensation we see, like Dr. White said, is that people are it's not that their hip flexor's weak, you can test it, it just is not ready to do a repetitive motion that much. And then what should we use for a criteria to return to sport? Some of the people I work with, we'd use the sport test, and I think that's great at testing the posterior chain. I can't ever tell you the last time I did a hip sport test because I don't use it all that often, and I don't know how many of you are familiar with it, but it's a lot of single knee bends, a lot of lateral agility, some pivoting and twisting, and most people, by the time they take it, they're good to go. But I think one of the things we neglect is the iliopsoas, especially for as many runners that we have and want to get back to running, or some type of soccer or whatever it involves that's very much large open chain when they start to play competitively. So that's kind of my gist of everything as far as things that I've questions that I've tried to answer from here.
If that's painful versus not painful.
So if it's painful, what I usually think is that it's not that it's any different, it's that it's a lot more sore, because usually when you load the joint, it takes some of the sensitivity away. It's kind of how I judge how flared up they are. So when you put them in quadruped rocking, and if they can't rock back anymore and they could do it previously, then something's a lot more sore than it previously was. So it's just more of a sensitivity test as opposed to is there anything different going on? Because most all the time you put people in quadruped rocking within 4 or 5 days, it feels great and it's their favorite exercise. So for that to become painful all of a sudden, then I'm like, you've probably done something that's really irritated the joint.
Joe, with your higher level patients who wanting to get back to running and Ganz execute, what do you like to do to get that hip flexor down?
I've been toying with this a little bit. I mean, what I've been having some patients do earlier on is a little bit of just TA with marching. But what I've started doing is just very basic reverse lunge. So going down like if they were standing on a step here, and it was this position, little to no weight on their front foot, and then they go down, and then they have to bring themselves out of it very slowly. You can either do that with a TRX or some type of assisted activity, but that's the one that I've been using the most. Sometimes I do have them do sprint mechanics, where they stand on a wall and they try to pull in their core, and they're basically firing their leg through a running type motion. And I do that, and we start out very slowly, but then we start to pick up the speed, and they try to do that for like a minute, but usually they don't make it a minute in the first time. So I try to use that a little bit more. We let them, too, if they can get in the pool and kick. I think that's a good way to do it, but that's only going to get so far because most people, unless they're a triathlete, don't like to get in the pool and kick that much.
No, the only thing that you don't want to do this stuff too early.
Right.
Yeah, so this is, you know, I'm getting kind of scared here. I'm nervous, Joe. I'm nervous.
So earlier on for cardio, I know I've read treadmill is not a great idea. What do you think of elliptical?
I let most of the patients get back on the elliptical at about 8 to 10 weeks, because they're usually not having any issues. They're farther enough out, and we're doing some pretty high level stuff. But that's usually kind of where I hold them to, is the 8 to 10 week mark. Because once I get past the 12-week mark, and Dr. White tells his patients this, you're pretty safe to have a flare after that. But that first 12 weeks, if you can avoid any type of flare, so I'm more apprehensive and let him try that stuff. And if they've had any type of flare incident, then I probably am going to wait a little bit longer.
Yeah, and I mean, for me, Sean and I we're preaching the whole time. It sounds really stupid, and perseverative in that we just said everything is slow. It's a 6-month race. And so, for me, I actually would probably push the elliptical out a little bit more, 3 or 4 month range, because I do see some flares in 2 to 4 months that can be pretty severe. Everybody's different in what they come up with, and that's why I'm kind of against the bubble sheet of kind of saying when it's safe, because you'll know if somebody is walking terribly and they've got this horrible weak gait, they start going into Trendelenburg. That's not somebody just because they're at 4 months you can put on an elliptical. And so, in general, for me, I typically say start picking up the resistance around the 3-month mark. If you want to start kicking a little bit in the pool, I think what Joe's talking about is a lot of short arc stuff, really simple stuff. But for swimming with kicking, I typically wait on that for about 4 or 5 months because everybody's different. I just don't want to initiate a flare. And then for me, a running progression usually starts around 5 months, and that's jog walking about a mile. And so these are sort of the ultra conservative side I have because to me, I don't want to sound insensitive, but I don't like it when patients don't do well. It really bothers me. I mean, we can have 40 patients that do well and 1 that doesn't. That's the one I'm going to take home for weeks until I find out they're doing better. And so I'd rather people err on the side of going slow. To me, I really hate it when people come in at 2 months. Like I don't want to brag about the ones who come in at 2 months that are doing super well, and that's awesome. I'm impressed with where they're able to go with the joint motion alone. Because that's all I'm really testing. When they come into the clinic, I'm testing the joint motion. The muscle strength and everything else, I have to defer to you guys. But for me, I just don't want them to kind of ramp up and fall down. Because the worst patient is the patient that does well, is really, really happy with you and then flares and then comes in really unhappy. Because a lot of times I'm hamstrung as to how to get them back. And a lot of times they don't want to regress and go back on crutches and things like that. I'd rather people take their time and stay on crutches for 8 weeks. I love that. I love seeing you on crutches. I love it.
For the swimming.
But that's what I kind of want. I want everybody to take their time because this is a marathon. If you go slow, it makes me very happy.
But as far as the cardio stuff, I'll let them, like with a pool buoy. I don't let them kick. And I always tell any patient that comes and see me and then is leaving, if they're coming from out of town, is the one thing you learn from leaving me is that you're never to have a pinch in the joint with any exercise, ever. So if you're 3 sets of 15 of squats or whatever, and on the 3rd set of the 10th one you get a pinch, you stop that exercise today. We may can come back or we need to modify your form. But they don't ever have any pain that reproduces that symptom actively ever. So that's one thing that I really preach when they come into me, and I was like, you may not follow this dot sheet or do exactly what I say, and that's fine, but this is the one thing that we can't negotiate on. You can't have this, because if you have it once and you get that therapist, oh, just push through it, then that's when the people get into trouble, is they went through that and they shouldn't have. And then as far as when I do have them get in the pool and kick, I usually make them use a board, and they have to do like just super slow, like very exaggerated kick. I don't let them kick fast. I said it may take you 10 minutes to reach the other end of the pool, but it's just some slow motion just to get a little bit of activity. What you could also do is, I have it do it in some patients that I'm less concerned with, is just when you add the walking is to do some marching as well, just really slow, so the buoyancy kind of brings their leg up. And then again, can't have any pinching, and if you do, you stop that exercise immediately.
And I think, it's Dawn here. She came up with a really good thing that helped. You see, what she told me that I thought was really helpful was she said, if I have some pain with an exercise, or it feels like a muscle soreness, but Dawn, why don't you tell me what she said? I don't want to mess with you. I'm sorry. You okay with that? And if it lasts into the night or the next day, we're a little bit concerned and we back off that exercise for a week or 2. That's a really nice, helpful, concrete rule that just helps you stay out of trouble. And I thought that was perfect. So the nice thing about all this is we have a lot of physical therapists now that have gone through it. Those are sort of our super resources. And Joe's definitely one of them, Dawn's one of them. And so, Van, it's good to just kind of talk to your colleagues. And that's what's so wonderful about all you guys coming tonight. This is wonderful for you to know each other and talk to each other, because this is hard. This is not like rehabbing an ACL or a rotator cuff, and I think collaboration is the key.
A lot of things can go wrong.
Yeah, a lot of things can go wrong, and it's not always easy to figure out what it is. That's for sure. Great. Oh, thank you. And then special thanks to Libby and Angie, for videotaping this. We'll add this on the web. So if your colleagues want to take a look at it or you want to take a look at it again, we'll figure out the best format to do it. But I really appreciate everybody coming. I really appreciate Bill putting this together. That was wonderful. Yeah, this was great. So thanks again. We'll try and do it again next year.
Thanks.